Well, good afternoon, ladies and gentlemen, from a cool and chilly Cape Town. It's wonderful to have so many hundreds of people logged on with us. And it gives me great pleasure to welcome to this webinar Dr. Carolina van der Westhuizen. And she's going to be speaking about menses and mena. No, she's actually speaking about heavy menstrual bleeding. And she's sponsored this afternoon by Bayer. And with Bayer, we have Tina Visser. So it's a wonderful, wonderful opportunity we're going to enjoy for the next hour. And hopefully, Carolina will be able to answer the questions as they arise. The first thing is we're going to be listening to a Bayer video and seeing the Bayer video. It gives me great pleasure to have my co-presenter as Professor Stephen Jeffrey. My name is Peter de Jong. He's Stephen Jeffrey. And of course, we have the ever faithful Chris, who's going to be doing the slides and ensuring everything runs smoothly. So without further waste of time, hello, Carolina. Hello, Tina. And Bayer, thank you very much. Heavy menstrual bleeding, let her roll.
That's the thing. Carolina, may I ask you, would you just quickly stop sharing so I can share the video?
Oh, yes, of course. Share. Is that
While
it?
she's sharing, she's presenting vicariously from Limpopo, where she does a clinic. It's important for us to know that she's been very generous with her time. And of course, she does this satellite clinic in Limpopo because there's no gynecologist there. And she generously goes up. So, Carolina, gaan ons 'n bietjie voort dan?
Ja, en 100%. Ek het nou 'n share gestop as as Chris die video wou speel.
Chris, can you share the video, please?
Working on it. So I just need to quickly change the setting here so that there can be sound. And then we are
Bayer's
ready
video.
in 2 seconds. There we go.
Every single month, blood. So much blood. The lost moments, the sacrifices I've made. Is this heavy period normal?
I've been told it's common in menopause, but my whole body's on fire. Dripping sweat. The sleepless nights, ups and downs. Is it normal I suffer in silence?
The desire's gone, vanished. The growing distance, feeling sad, guilty. Is this quiet battle normal?
Every time we get too close, the anxiety hits. What if I get pregnant? Is this fear normal?
With every period, the cramps, the agony. I'm the one who misses out, can't be there again. Is this unbearable pain normal?
You know what hurts in women's health? Being told everything is normal. Because if something is holding us back, it's anything but normal. It's time to question what we've been told and confront what we've accepted. It's time to reclaim the moments we've missed. Women by Bayer is here to reveal what's not normal in women's health. Raise your voice and share your story at women.bayer.com. Together, we can create a life without compromise and embrace every single moment.
Thank you very much indeed to Bayer and Tina Visser. And Carolina, thank you once again. You're presenting all the way from Limpopo. We hope the internet is good. And if you could start sharing your slides, please. There we go. Carolina van der Westhuizen, a women's health practitioner from Mediclinic. And she's going to be speaking about heavy menstrual bleeding.
Thank you kindly, Peter. And I thought it was only cold up here in Limpopo. And so I think it's the whole country that's in a cold grip, but I hope everybody is warm and comfortable during this information session. We actually had a laugh earlier about sign language, and that's why I started with this first slide of menses and mene. And menses is a Latin term for flood and or flow, and mene is the old Greek term for moon. And this is how we think about menstruation. It is the moon cycle of a woman every single month, and it doesn't matter what language you speak, sign language or the other 11 official languages in South Africa. I think there's 190 official languages in the world. Menstruation affects us all directly or indirectly, positively or negatively. So, and that's why Bayer also asked me to talk about menstrual cycle and specifically heavy menstrual bleeding. So, specifically today, I will talk about heavy menstrual bleeding. It falls under the umbrella of abnormal uterine bleeding. And we actually try to get a classification system that get rid of terms that we don't always understand. And so we have to have a universal language so that patient and physician can actually understand what the patients are talking about. So if we look at the literature and where do we stand with research on menstrual health, and we see menstrual health is actually one of the black sheeps in gynecology. It does have much less literature being published than cervical cancer and ovarian cancer, but it's definitely getting better. So publications are picking up, and we actually initially thought, but why is it that publications are so difficult and not a lot are being talked and written about menstrual health is because we think it is a normal process that is not necessarily associated with distress and disability in the majority of females. But even in a normal cycle, it can be catastrophic to some females, like patients who are handicapped. And we also lack standardization of tools and different etiologies that's also causing abnormalities in the menstrual cycle. Just to show that literature are picking up, and specifically there was a nice peak in 2021, 2022, and then actually another peak in 2024 about publications on menstrual health. So then why and what about menstruation? It is because it forms such an integral part of a female's all-over health. And we know that abnormal uterine bleeding is actually the single most common complaint that reproductive women will bring to their physicians. So we need to understand the underlying phenomena of menstruation, and we also need to understand the mechanics of menstruation. And then that will lead to the question, actually, why do we menstruate? And the most honest answer that we can give is we don't know. We don't know why humans are menstruating. And we are only 1.6% of placental mammals that are menstruating, and of which we share this with sloths and elephants and bats. So we are just but a little bit of the percentage of mammals that are menstruating. And we mustn't confuse it with the bleeding that a dog might have when she's in estrus. That is not a menstruation. That's only a sign that she's ready to mate, and it's not a breakdown of the uterus. So we don't know why we are menstruating. So how do we actually look at menstruation? And it is described in 4 simple domains: frequency, regularity, or the predictability of menstruation, the duration, and then of course the volume. So we will speak in this session about the volume, and the duration is also part of the heavy menstrual bleeding definition. And what's very important is that we need to remember that progesterone withdrawal is a trigger for menstruation. And 30% of women will have an alteration in their bleeding volume and frequency of their menstruation. And how do we measure menstruation? And there are a few tools that I will come to later on. But what's very interesting is that down in the slide, you will see previously women only experience menstruation cycles approximately 40 times in their lifetime. And that was due to the fact that they had much more pregnancies and they also lactate for much longer. Whereas in the developed economies today, females are actually menstruating up to 400 times in their reproductive cycles. And this
Carolina,
actually,
sorry,
yes,
Carolina, you don't mind if I interrupt? Does that mean
no.
it's 10 times, modern women menstruate 10 times more than women previously? And if we looked at the San Bushman woman, and they also only menstruate 40 times for the same reasons you've given. Does that mean that it's abnormal to menstruate? Because the San Bushman women don't have endometriosis as much, anywhere near as much as we do in modern countries. Does that mean it's abnormal to menstruate?
No, it's not an abnormal phenomenon. It was just much more infrequent. So they're iron stores, and they didn't experience blood loss as much as women that's menstruating nowadays. So this is a much more frequent process, an event that is taking place. And so if you lose blood, a fraction a little bit above normal, it will accumulate and then it makes women sick. And so it's not abnormal to menstruate. It's just a much more frequent event than it was in the past. So
Thank you.
if they had a heavy menstrual bleed once in a few months, then it was less of an impact on their lives than if you menstruate much more than that, even in 400 times in your lifetime.
Okay, thank you.
So this actually underlines the importance of how the menstruation starts and what are the processes involved in cessation of menstruation. So, and then heavy menstrual bleeding specifically, that is what we are talking about tonight. And when Bayer asked me to talk about heavy menstrual flow, I immediately think of the two biggest waterfalls in the world, and Niagara waterfalls in America, and then a little bit closer to home, the Vic Falls. And I asked my husband when he walked past, when I was busy with my slides, which one do you think is the biggest waterfall? And he was actually wrong. So this is just a quick quiz, and we can answer that a little bit later. And why I was thinking about the waterfalls is because women usually normalizes excessive bleeding, and they will say, I bleed a lot, but I think it's normal. So how big is this waterfall every single month that they are experiencing? And we call it the hidden epidemic. Why? And it is because 46% of women will actually never sought medical help because they think it's normal. So they will not represent themselves to the doctor. And only when we do special investigations or when they start feeling tired or short of breath, then they will come and say, but I think there's something wrong with me. So 1 in 5 women will experience heavy menstrual bleeding, of which 80% also have negative impact on their work or in their schools. And then, of course, 25% of all gynecological surgeries are attributable to heavy menstrual bleedings. And to make things a little bit more confused, we have different definitions, and we've got traditional terms and new terms and old terms that try to describe abnormalities of the menstrual bleeding. So from amenorrhea to hypermenorrhea, and then to confuse people a little bit more, we talk about abnormal uterine bleeding and dysfunctional bleeding. And but tonight we're going to specifically speak about heavy menstrual bleeding. So the old terminology versus the new terminology, and we really try to make it simple So the modern FIGO approach is to actually describe it in layman's terms, so plain terms. So doctors need to speak about irregular menstruation patterns or heavy menstrual bleeding, and the same applies actually for patients, so that we can understand what they and we are talking about. So how do we measure menstrual bleeding? And this is once again just a new article to show that we are picking up on publications of menstrual health, and it is on the quantification of menorrhagia, and it was published in the Journal of Hematology in 2024. So there are different tools that we can use, and I will come to that in the next slide. So what is heavy menstrual bleeding? And the National Institute for Health and Care Excellence, and that is a UK-based organization, published guidelines in 2018 on heavy menstrual bleeding and the assessment and management thereof. And then they updated it in May 2021. And they still have the quantifying part of menstruation that includes more than 80 milliliter blood loss per cycle, and or the cycle is longer than 7 days. But what's very important, they bring in the patient-centered part of the definition, where a patient herself determines whether her bleeding is a problem or not. And to define heavy menstrual bleeding, we need to know what are the normal limits of menstruation. And so the definition then of excessive menstrual blood loss, which interferes with a woman's physically, emotional, social, and material quality of life. So then the assessment tools, and there are a few, and some are practical and some not so practical, but it's out there, and they are on platforms for women actually to help them to see whether they have a problem with their menstrual flow and with their cycles. So the pictorial bleeding assessment chart, and then the menstrual pictogram, the menstrual bleeding questionnaire, the HELP questionnaire, the Philip tools are all out there for patients to be helpful to identify their cycles. And luckily, there's progress in menstrual health literacy. So the My Health apps, and there are currently more than 300 products available. And the largest two apps include the Flow app and the Clue, and they may assist in identifying women with abnormal uterine bleeding or heavy menstrual bleeding. And then, of course, a mycontraception.co.za. So it's a drop-down application where you can actually drop down up to heavy menstrual bleeding, and then patients can actually take the quiz on their periods. So this is just a picture of the pictorial blood loss assessment chart. And then, of course, you can direct visualize the blood loss, normal, and it's actually quite few people that actually realize that menstrual blood flow is actually only 2 to 3 tablespoons in a cycle, so up to 30 and 40 milliliters per cycle. And then heavy menstrual bleeding, more than 80 milliliters per cycle, and that equals more or less a third of a cup. So the pictorial bleeding assessment score, if the patients have more than 800 points, it actually correlates very well with a blood loss of more than 80 ml of blood per month. So how can we actually get to a system that we can talk the same language about the diagnosis and how to treat patients? And then a classification system was actually determined by FIGO to help determine the causes and management of chronic abnormal uterine bleeding in the reproductive years. So the first system actually focuses on the terminology, and it encourages the physicians actually to remove ill-defined terminology such as menorrhagia and dysfunctional uterine bleeding. And the second system actually focuses on the underlying causes of abnormal uterine bleeding using the acronym PALM-COIN for structural and non-structural causes. And of course, these two systems are running together to make diagnosis and treat patients. And so it is actually hoped that these two FIGO systems will be used globally, so to actually have a standardized language, so to speak, to improve the management of women with abnormal uterine bleeding. And this is just a picture to illustrate it visually. And then, of course, the PALM-COIN classification on the left-hand side are the structural reasons for heavy menstrual bleeding. That includes polyps and adenomyosis and leiomyomas and malignancy. And then, of course, a non-structural part, the COIN part, coagulopathy. And I think this is very important because I'm going to highlight the screening for coagulopathy abnormalities. Ovulation dysfunction, and then endometrial reasons are also sometimes overlooked in the screening and diagnosis of heavy menstrual bleeding. And then, of course, iatrogenic reasons like the copper intrauterine device. And then there are two reasons or conditions that's not yet been classified. And what's very important is we need to think systematically because sometimes more than one etiology can actually coexist in a patient. So if you look at the PALM side of the classification system 2 of FIGO, then we see polyps causes 5.7% of heavy menstrual bleeding in patients. And so if these patients have recurrent intermenstrual bleeding, you need to evaluate them for polyps. And adenomyosis contribute to 14% of heavy menstrual bleeding, and leiomyomas almost 11%, and then of course malignancies and hyperplasia. I'm not going to give a broad information talk about malignancies and hyperplasia, but it is very important to just underline that hyperplasia, endometrial hyperplasia, is a diffuse abnormality in the endometrial cavity, whereas a polyp is just a localized kind of hyperplasia that is not necessarily abnormal. So endometrial hyperplasia with atypia, you have to remember this is a precancerous lesion. And it is very striking that 41% of occult endometrial cancers were actually identified after hysterectomies for complex atypical hyperplasia. So the non-structural causes, very important, and I think not everybody screens for this, is the coagulopathy abnormalities. It can be inherited or it can be acquired. So we mustn't forget the acquired part of the coagulopathy abnormalities. And 30% of patients with heavy menstrual bleeding actually have coagulopathy. But the number one group of patients with coagulopathy abnormalities are the adolescents. They get the golden medal for this. And the most common ones are, of course, von Willebrand's disease and platelet dysfunction. And ovulatory dysfunction, also a big portion, almost 60% of adolescents will have an ovulatory abnormal bleedings. And then don't forget PCOS and then thyroid specifically as well. And as I've mentioned, endometrial causes, chronic endometritis, actually also are causing damaging to the subepithelial capillaries that causes breakdown and bleeding, and this are quite overlooked quite commonly. So iatrogenic, the copper intrauterine device, and then of course anticoagulants we kind of used to, but what is surprising is we must remember a big portion of our female population do use antidepressants, and the SSRIs actually also causes abnormal uterine bleeding. And the underlying reason is because SSRIs inhibit platelet aggregation, and that reduce the capacity of a blood clot formation, and SSRIs inhibit the serotonin transporter not only in the brain but also in platelets, and that leading to a depletion of serotonin within platelets. And then, of course, the ones that's not being classified, and that will be arterial venous malformations and myometrial hypertrophy. So we are looking at new models that control the onset and, of course, the cessation of normal menstruation. And the onset of menstruation is actually enzymatic autodigestion of the functional layer of the endometrium and its subsurface capillary plexus. And the cessation actually involves a lot of vascular roles and, of course, also coagulation mechanisms. So we know about the follicular phase, the ovulation phase, the luteal phase, and what different things are happening in the endometrium. And then, of course, the trigger is a progesterone withdrawal. So, but what stopped the menstruation, and that is very important, and that is vasoconstriction of the spiral arterioles in the basal layer, and then platelet plaque formation. So, where the SSRIs, for instance, are inhibiting this process, and coagulation activation. And this is why coagulation disease screening is so important. And then we get rapid re-epithelialization from the basal glands. And this converges actually already by day 5. And that's why if you have a prolonged bleed, like in longer than 7 days, it is abnormal. And then, of course, new vessel growth coincides with the rising in estrogen levels. So how does abnormal uterine patterns look like? So we get 4 actually abnormal uterine patterns, and number 5 is actually a normal pattern. It is what we expect every month, like clockwork with our menstruation. So the abnormal ones are estrogen withdrawal and estrogen breakthrough, and progesterone withdrawal and progesterone breakthrough. So the one that actually gives us the most profuse bleeding is the estrogen breakthrough bleed. And this is associated with chronic anovulation in our obese patients and PCOS patients. So you get in some patients, and specifically in the adolescents, very profuse bleeding. So they have specific characteristics. So it can be transient spotting, or you have a period of amenorrhea with an ovulation and then profuse bleeding, or you can have with progesterone breakthrough just intermittent light bleeding. So why does an ovulation actually causes bleeding? And it is because there is no progesterone production. So you have this continuous unopposed estrogen production. So you have the whole time you have proliferation of the endometrium. And this actually causes a disorganized endometrial growth. You don't get any stabilization with a progesterone effect. And then this disorganized endometrial growth causes dilated fragile vessels. And then you get this focal rupture. So one part of the uterus, the endometrium starts to bleed and it breaks down. And then it starts to repair. So you get this patchy repair effect with an ovulation. And when this part of the endometrium starts to repair, you get another part of the endometrium that actually starts to bleed because of the fragile vessel. So this bleeding pattern is totally unpredictable. So you have this with this profused, continuous unopposed estrogen. You have this abnormal vessel density, and you have abnormal enzyme release. And that leads to prostaglandin imbalance between E2 and F2 alpha. So you have more vasodilatation than vasoconstriction in the blood vessels. And you also have inhibit platelet plaques that forms. And as I've mentioned, you get this total fragile, patchy repair and continuous abnormal bleeding with and ovulation. So it is perfused because it's this whole time this endometrium is growing, so nothing is stopping. So you don't get a universal breakdown of the endometrium and then stop with your cycle. It just continues for weeks. So you get this pale, frightened teenager that is bleeding for weeks, or you get this worried premenopausal woman that is actually worried that she does have cancer. So what is the true prevalence of heavy menstrual bleeding, and can we try to quantify the physical burden on women? So the prevalence in the general population is between 10 and 30% of patients will have a burden of their menstrual cycle. And when you ask them about the quality of life definition, it is actually shocking that half of women will tell you that this is a burden for them. Adolescents, a very high percentage of them will have heavy menstrual bleed. And so they are a very special group of patients that we need to attend to. And then also in the low income countries, we have this heavy menstrual bleeding burden. And don't forget the silent companion of iron deficiency. I'm not going to talk about iron deficiency and what the recommended daily dosage is in teenagers and in bleeding and non-bleeding patients. But what is very obvious is that 3/4 of patients with heavy menstrual bleeding either require oral transfusion or do have an iron deficiency or are anemic. And almost 9% might require an IV drip, and then 4% might even require a blood transfusion. And what is also new is there's a recent article published that actually quantify that 15% of patients will have an increase in risk of depression. So this article was published in South Asia. It's a article that was published a few years ago. I think it was in 2023. And the conclusion was actually that the findings highlight the substantial burden of heavy menstrual bleeding on a woman's mental health. And so they recommended that heavy menstrual bleeding should form part of the comprehensive treatment in women in their reproductive years. So this is just a hypothetical chart of how depression actually can develop with heavy menstrual periods. And then if we look at the social, psychosocial and the economic burdens of heavy menstrual bleeding, then we will see that 86% of patients forms or report negative life impact. And it includes millions of pounds and millions of dollars in certain economies. And 54% of patients will take sick leave due to their heavy menstrual bleed. 80% have negative impact on their work and school performance. And 82% feels that their relationships are negatively affected. This was a very interesting article that was published in the Journal of Gynecology, Obstetrics and Human Reproduction in the United Kingdom, and where they actually compare the levonorgestrel releasing intrauterine system against laparoscopic assisted supracervical hysterectomies for the treatment for heavy menstrual bleeding. And it was an economic evaluation. And what they actually find was that the increment cost-effective ratio was calculated that it will not be cost-effective to replace the golden standard of the treatment for heavy menstrual bleeding, that is the levonorgestrel containing intrauterine system with the lash. And then if we look at age-specific patterns of heavy menstrual bleeding, that might also help you to identify the etiology of what the abnormal bleeding is causing in these patients and to help you with treatment. We see that adolescents, the number one and the number two is an ovulation. As I've mentioned, you get that frightened teenager who are bleeding for weeks. And then, of course, the bleeding disorders. Up to a third of adolescents, even if not more, actually have inherited bleeding disorders. And remember, PCOS, 25% of patients in the adolescent years will have PCOS, and that actually falls also under an ovulation. The reproductive years, causes are more structural and in the perimenopause. And remember, only 15% of patients actually have absolute 28-day cycle in the reproductive years, and that's actually quite a small percentage of patients who will have a 28-day cycle. Perimenopause, also very important to remember, you always have to exclude malignancy, especially if the patients complain about increasing in the menstrual flow very late in life and it's not an ovulatory, you always have to exclude a malignancy. So just to look at new articles on the evaluation of heavy menstrual bleeding in the specific age group of or the population group of adolescents. So we see these group actually have in the majority of times when they have heavy menstrual bleeding, it is an excessive bleeding. And that might result in acute anemia that might require emergency treatment. So if you look at the Journal of Gynecology and Obstetrics of FIGO, then what they also found was that 11.6% of patients in the adolescents have bleeding disorders, and you have to screen for that specifically when their hemoglobin is less than 10. And if they have persistent bleeding despite treatment, you have to reevaluate that adolescent and screen them for bleeding disorders. Luckily, oral contraceptives are quite effective in reducing hospitalization, transfusions, and improve these teenagers' quality of life. A very recent article published end of last year look at the current gynecological management of women and girls with bleeding disorders in the United Kingdom. And what they found was that despite very heavy burden on health in females, they actually recently decided to actually have a protocol in treating and up the gynecological care in women and children with with bleeding disorders, and that whereas 4 of every 5 patients actually experience very heavy menstrual bleeding with bleeding disorders. So if we look at the bleeding disorder group then specifically, then we see that the most common bleeding disorder is von Willebrand's disease. And von Willebrand's factor breaches the platelets to the endothelium, and that carries then factor 8. And 93% of patients with von Willebrand disease will report very heavy menstrual bleeding, of which 85% is during the adolescence. So more than 50% of patients that's registered in the United Kingdom with bleeding disorders are actually women, and less than 50% are males, and they actually recently did not have protocols to look and screen and treat patients with for heavy menstrual bleeding with bleeding disorders. Please remember there are testing nuances, very interesting. Patients with type O blood group, they have lower von Willebrand's factor. And also the menstrual cycle affects the screening. So sometimes you need to retest a patient a few days in a cycle into a cycle. And then there are new tests like the PFA, and I will say a little bit more on the next slide. The PFA 100 is actually a new modern test that's replacing the bleeding time due to the fact that it's less invasive and that does have greater sensitivity. Just a quick slide on the inherited bleeding disorders. And then please remember, and this is to confuse everybody a little bit more about bleeding disorders, we do get acquired bleeding disorders, and these conditions develop during a person's lifetime. So it is unlike inherited disorders. So these patients might not even have a family history of bleeding disorders, and then this acquired bleeding disorder result in an inability to form a proper blood clot, and that leads to severe bleeding. The interesting thing is how one can distinguish clinically between acquired bleeding disorders and inherited disorders is that inherited hemophilia A, for instance, only give localized bleeding, whereas with the acquired bleedings are much more profusely through muscles and subcutaneously. So you get an acquired hemophilia A. It is a rare autoimmune disorder where the antibodies inhibit coagulation factor 8, and it often affecting elderly patients. And we must remember it can also occur postpartumly, and they actually mentioned that risk factors for acquired hemophilia A is pregnancy and the postpartum period. And these patients can actually have delayed postpartum bleedings up to 12 weeks. So we need to think once again about the pattern and to screen for these acquired diseases. And then just to mention, acquired von Willebrand's syndrome is where patients actually also have hypothyroidism. So hypothyroidism can actually also cause acquired bleeding disorders. Vitamin K, vitamin C deficiencies, and then once again drug-induced disorders. We all are aware of aspirin, the antiplatelet agents, and the anticoagulation agents. And then, of course, don't forget the SSRIs. So, and it's very complex. So sometimes this involves multiple clotting factor deficiencies, and this is sometimes really difficult to treat. But when you treat these patients, you need to address the underlying cause. So if a patient does have hypothyroidism, you have to treat that first as well. Endometrial hyperplasia, I just want to talk about the biopsy thresholds just quickly because you need to screen patients with bleeding, and if they have a thin endometrium, a biopsy is not necessary. So then this endometrium is attenuated and you need to treat them first with estrogen. And then if you have a patient with endometrium thickness between 6 and 12 millimeters, some of the American data will say 11 millimeters, you have to biopsy if patient does have risk factors. And of course, even without risk factors, if you have a thick endometrium, especially in a menopausal period, then you have to biopsy. So of course, we need to be a good investigator so that we can treat correctly and do the proper diagnostic and therapeutic procedures. So diagnostic algorithm, I'm not going to spend a lot of time on this because it applies to the majority of illnesses that we deal with. And people are sometimes asking, should we do a progesterone test? If you want to see if a patient is ovulating, then of course you need to do it in the luteal phase. So if you have a sudden departure from regular patterns, always exclude a pregnancy first. If a patient does have regular heavy bleeding, think structurally or bleeding abnormalities. And if it is irregular and unpredictable, think about anovulation bleedings. So then just once again, a recent article that says many diagnoses were associated with bleeding disorders and therefore warrant investigation when assessing patients with heavy menstrual bleeding of unknown etiology. So history, yes, of course, always look at the pattern, look at the duration. Is it post-coital associated symptoms? systematic or illnesses, and then of course medications that can cause abnormal bleeding. And then of course try to establish the source of the bleeding. So we need to examine the patients. So often I do see patients that's been referred, and then I ask them, did the doctor examine you? No, the doctor only did some blood tests. So we need to put hands on patients to treat them and assess them correctly. So what about the laboratory investigation? So we spoke about anticoagulation or coagulation deficiencies or abnormalities, but we always need to do a pregnancy test. That is the first test that we need to do. We need to do a full blood count, iron studies. Of course, we need to look at coagulation pathways from Willebrand screening. Then I've spoken about the PFA test. Thyroid test we also need to do, it's not on the list, is prolactin. We can do serum progesterone if you are unsure about ovulation, endometrial biopsy when it's warranted. And then, of course, we need to test patients for chlamydia, gonorrhea, trichomonas when they have clinically vaginitis or cervicitis. That can also cause abnormal bleedings. And, of course, a pap test is always warranted in these patients. So once again, laboratory screening in large series of women, then at 10% we need to screen them for anticoagulation abnormalities. So what about imaging? What are we looking at, and what instrumentation do we need to look and image the patients for? And the first line imaging is, of course, transvaginal ultrasound. What is much more sensitive nowadays is we advocate for saline infusion sonography. And then hysteroscopy is the golden standard. Nowadays, lots of doctors are doing office hysteroscopies. It's minimally invasive, but the majority are still doing theatre procedures. And then, of course, MRI are selected for specific cases. So how do we treat these patients? And if there is no pathology or small fibroids or adenomyosis, the number one treatment is the levonorgestrel containing intrauterine system. Of course, you can use a tranexamic acid and NSAIDs together with initially with the intrauterine system. And of course, oral contraceptives are also used as second line or even first line, depending on what the preference of the patient is. And then, of course, if that doesn't work, we always refer to and move to surgery. Fibroids bigger than 3 centimeters, you can treat them first and then operate. And then, of course, if you suspect pathology, we do biopsies. So what is the mechanism of working with the intrauterine levonorgestrel system? It works locally. It does have minimal systemic absorption. Always quantify it in the form of comparing it to the levonorgestrel oral contraceptive only tablet. And I say it equals the amount of progesterone as if you take an oral contraceptive every 5 to 7 days. So it is 80% effective in reducing menstrual blood loss at month 4. It does take a little bit longer than oral contraceptives, but the longer it stays in, the bigger the reduction of bleeding. So the hemoglobin in studies also increased from a 9 to 0.4 to 11 in 4 months' time. So you can extend the Mirena. There was the Mirena extension trial, but for contraceptive purposes and heavy menstrual bleeding purposes in South Africa, it is only registered for 5 years. It's also very effective for treating adenomyosis. Bleeding disorders, I will mention something quickly about the intrauterine system, about bleeding disorders. And of course, we also use it to protect the endometrium when we use it as part of the hormone replacement therapy regime in postmenopausal patients. So we choose the levonorgestrel device if you have idiopathic heavy menstrual bleeding, if you have small fibroids, if estrogen is contraindicated, if a patient still needs contraception and she wants long-term contraception, and then of course in the perimenopausal period and patients with bleeding disorders. So what about the oral contraceptive, Clara? So we use it. It is the only combined oral contraceptive that is licensed for heavy menstrual bleeding in some countries. So it is the first and only contraceptive, as I've mentioned, for heavy menstrual bleeding indication. It's a natural estrogen, so it acts more physiologically. And it does have a dynamic quadriphasic dosing and try to mimic the normal menstrual cycle hormone release. And the Dynagest in the tablet is very potent and does have a good effect on the endometrium, and it is anti-androgenic. We see the best result with the first menstrual withdrawal, 88% reduction. And then, of course, it does have a cumulative effect, does have a rapid onset, and the majority of people, the investigators and the patients, are satisfied with the effect of this product. So you use it when patients want to use oral contraceptives, and you also want to treat heavy menstrual bleeding if they prefer the pill over the intrauterine system. It's very effective in adolescents with heavy menstrual bleeding, patients with dysmenorrhea as well, and patients who does not want long-term contraceptive effect. You cannot use it as the same as with all the other combined oral contraceptives with a history of venous thromboembolisms, patients with migraine with aura. Smokers, please don't forget them. Patients are over 35 years, and then patients with hypertension or liver disease. So just a quick thing about head-on-head, the levonorgestrel containing intrauterine device, and with the estriol valerate product with Dynagest. So the big difference is patient choice, and then the onset of working with the oral contraceptive is a little bit quicker than with the device. There are other methods to use. Tranexamic acid, 72% effective in von Willebrand's disease. And what's very important is a 19-year study actually don't show any increase in venous thromboembolism risk with tranexamic acid use, and it does have fewer side effects in adolescents. Non-steroidal anti-inflammatory tablets between 20 and 40% effective in reducing menstrual blood loss. So the consensus, there was a consensus article about the use of tranexamic acid in treating of heavy menstrual bleeding in adolescents, and it's only when the bleeding was cyclic that it was very effective. Progestin therapy alone, you can either use it cyclic, then it's high dosages, and then of course you can also use, and it's not a contraceptive, I have to mention, so it does not suppress ovulation. So if a patient does need contraception, then you cannot use cyclic progesterone, medroxyprogesterone acetate. The estrogen progesterone contraceptive tablet is a better choice if the patient needs estrogen or contraceptives, and if she still ovulates. So Depo-Provera actually is not a treatment for acute bleeding, and it gives amenorrhea in 70% of patients. That can also be used, but this is for chronic treatment, not acute bleeding. And then a GnRH analog we use in certain cases. So when do we consider a menstrual suppression in patients with hematologic malignancy? So this is a list of treatments, and I just want to mention the levonorgestrel containing device. So if you are worried about bleeding in this patient, acute bleeding, or a lot of these patients might be immunosuppressed. If you're worried about an infection, better not put the levonorgestrel product in at that specific time because one can run into problems. So then what about acute bleeding treatment? So this is then for specialists, it's not for GPs. GPs needs to refer these patients. If they're hemodynamically unstable, they need to be admitted. Of course, some of these patients can really bleed very profusely, and then you need to tamponade, and then IV estrogen is the treatment of choice. Remember the risk for venous thromboembolism, and remember the patients can get seriously nauseous, so you have to give an antiemetic together with this treatment. So just a note that I want to mention for adolescents protocols. So you have to use combined oral contraceptives with high dosages of ethinyl estradiol, preferably products with a dose of more than or equal to 30 micrograms. And in the first day, you give 3 times these oral contraceptive tablets for 3 days, and then 2 per day for 2 days, and then from there on you continue with daily. Remember, if you want to treat acute bleeding with progesterones, you have to give very high dosages of progesterones. So when medical treatment fails, we always use surgical treatment, and please image before you start treatment because you need to evaluate the fitness of the endometrium and then treat the patient accordingly. Of course, we have endometrial ablation, and there are studies you can do myomectomies, hysterectomies. There are newer techniques now where we use energy to shrink or laser or destroy or coagulate symptomatic submucosal uterine fibroids. So, and then once again, treatment in specific groups. I've mentioned that in the von Willebrand group, we give specific factors in those patients, tranexamic acid, very effective, and then of course oral contraceptives. In malignancies, we prefer the GnRH analogs, and then adenomyosis, the levonorgestrel containing device. And then in post-transplant patients, we want to stay away from hormones, so we give GnRH analogs, and then of course the adolescents, oral contraceptive, tranexamic acid, and always remember the iron. So this is just a decision flow chart. I'm not going to go through that. And then just clinical pills, what to remember. Heavy menstrual bleeding is a patient-defined definition, so you have to ask the patient, and we have to understand the mechanism. So does she ovulating or not? What is the pattern of the bleeding? Think the palm go in systematically, and age influence etiology. Think about that, and screen adolescents from menarche for bleeding disorders. It's very, very prevalent, and image before you treat. And the levonorgestrel intrauterine system is very effective. And Clara is the only combined oral contraceptive licensed in certain countries for heavy menstrual bleeding treatment. And then, of course, always suspect other pathology if your treatment fails. And remember that depot progesterone has no place in acute heavy menstrual bleeding management. Just to throw a stone in the bush and to complicate things, don't forget the gut. Gut also plays a huge role in patients' hormone regulation, so we need to think about that as well. And thank you.
Caroline, it's been wonderful. I'm eternally grateful for that beautiful presentation. We've got lots of questions. I've got a whole lot, but unfortunately, because of time constraints, I'm going to ask you to answer the following questions in 30 seconds each question. Premi Naidu, what about a reasonable explanation for heavy bleeding and abnormal bleeding in women using weight loss injections, Mounjaro? Have you found that, and what should be done in 30 seconds? If a woman's on Manjaro,
So it
do
does
they need
have
more?
liver effect. Yeah, so I don't think there are lots of studies out there, but if you look at what the effect of Manjaro is on the liver, so that can be a pathway that explains heavy menstrual bleeding. And then, of course, it does have an effect on ovulation function. So quick, heavy, or weight loss can disrupt ovarian function, and that can also be one of the reasons for abnormal bleeding in those patients. So always
Okay,
be cautious of liver and pancreas.
An anonymous says, just remember to always ask young women about when they're iron deficiency anemic before you treat them with the IV infusions, to ask them about their periods, especially vegans and vegetarians. And a final question from Moira Stain, can we leave a, can we leave a Mirena in for 8 years, seeing it's registered in most other countries, or from a medical legal aspect, we should take it out? A yes or a no for that?
No, it's an off-label indication in South Africa. You must realize that it's only registered for 5 years, and it's there's only that is for contraceptive purposes. So if she's in a different country with an extended time period, then it's their regulation. It's not regulated and registered for that in South Africa, unfortunately.
Okay, thank you very much indeed. We've got lots and lots of questions. Unfortunately, you're going to have to ask Bayer to bring Carolina back for a Q&A session. It's a very important topic. We have well over 150 people registered for this particular webinar. And remember, you all get CPD points for answering. And a special thank you to Carolina and Steve. Would you like to give the last word, Steve?
Absolutely, yeah. Thanks. Thanks. We listened with great interest. It was wonderful. I mean, such a important topic that we don't really talk about, and I think you highlighted that very well to us, Carolina. And again, I think we saw that palm coin already in 2009 at that first FIGO in Cape Town, and since then it's still not really been adopted very widely. People don't think about it enough, but you've given us food for thought, and hopefully we can get some traction with just a little bit more attention to this problem. And but thanks so much for a very comprehensive and thorough overview of this topic. And thanks very much for your time, and we do appreciate it. Thanks to Pete as well, Chris, and of course to Bayer again. Thank you very much for your input, and thank you very much, Pete.
And see you all safe home. See you all same time, same place, Carolina, next Thursday evening. Thank you very much indeed.
Thank you very much.
Thanks, Peter.
Bye-bye.
Thanks, Steve. Bye-bye.